can I invite the next panel to the stage here? We talked about AI in the previous session, and now we are going to go somewhere completely different, but also a little bit closer to home. And this is how telehealth evolved before, during, and after the COVID pandemic, and what did we learn, and what will stay, and what will disappear again. Now, a short intro, telehealth was already on the rise before the epidemic or the pandemic started, although it was adapted more slowly than what technology would have allowed. And there is a lot of root causes for that, and we will properly discuss these during the panel. Now, during the pandemic, we have seen a skyrocketing pace of telehealth being adopted by hospitals, by doctors, but also by patients, because it was the only, especially if you had a chronic disease, it was the only way to connect to your care providers, because physical visit to the hospital was nearly impossible. We saw also that in many countries, especially here in the US, reimbursement changes facilitated this virtual care during the COVID pandemic. And yesterday, most probably by coincidence, I read a report in the news of 5,000 patients that were interviewed, that were surveyed on the use of virtual care. And 3/4 of them, 75%, were very, very comfortable to manage their own care in a virtual way rather than going to the doctor in regular intervals. So we are going to discuss this with this very esteemed panel that is here with me on stage. I'm going to introduce them to you very briefly. First, we have Professor Thomas Brink, who is the Chief Innovation Officer, as well as being an orthopedic surgeon and an associate professor at the Mehiläinen hospitals in Finland. And then we have Dr. Ihsan Al-Marzuki, who is the co-founder and the managing director of Glucare Health, which is an integrated diabetes center in Saudi Arabia. And finally, it's a pleasure to introduce Dolores Paredes, who is the Vice President of Markets, Strategy and Innovation at Air Liquide. So let's go into the discussion with this panel. I'm coming to sit with you there. So the first question I would like to go into with the three of you is which kinds of challenges and as well as opportunities you experienced during the COVID pandemic, and how did you deal with it during these very challenging times? And maybe we can start with you, Thomas.
Thank you very much, Jan, and thank you for the invitation. Okay, a little bit of the background. Before the pandemic, our company Mehiläinen had 110 years of experience in healthcare in Finland, and also some 10 years of experience in creating digital solutions in healthcare. So we did not start from zero, but of course with the pandemic, well, the demand skyrocketed, as you said, and the demand exceeded our supply tenfold. So we needed to do something urgently. We needed more doctors, of course, but we needed also to enhance our workflow, and we needed technical solutions. And I will talk briefly through those solutions we did. So first we tried to improve how to direct the patient to a proper or the right digital doctor, so to say. So we created these automated symptom assessments, which based on answers, they directed the patient to specific cues. And these answers were used as a summary for the doctor, and they could also be blueprinted to the patient records, and that lessened the need for a doctor to type, and was efficient use of time also. And also we created these digital care pathways regarding typical illnesses with standardized treatment based on evidence-based medicine and best practices, for example, urinary tract infections. And doctors could launch those pathways with just one click. Also, we created preset phrases with which the doctors could communicate with the patients and provide precise and accurate information quickly. So these technical enhancements, they freed actually the time for our doctors to do the communication and the decision making. Also, we enhanced the user interface in cooperation with our doctors, and we try to keep it as simple and intuitive as possible. And actually, in addition to that, of course, we recruited and educated new doctors, and we needed to inform our patients with this new digital access to care. Yeah, and I think we succeeded in that because, you know, we were asked to share our digital platform with also other healthcare providers, and that created a subsidiary called VBHC, which is an kind of like a white label, modular and customizable digital platform, and it is used in Finland in some parts by public healthcare, and also, for example, a company called Mediclinic, which has divisions in Switzerland and Southern Africa and in United Arab Emirates also. So yeah, to wrap up, you know, we were surprised, of course, by the overwhelming demand of digital healthcare with the pandemic, but luckily we had some background from the pre-pandemic time with the digital solutions already. So we had something to build on.
I have really a burning question, follow-up question, but I would like to go first to our next panelist. You are a native virtual care provider almost. Can you talk a little bit on maybe on your company, how you're providing diabetes care in Saudi Arabia, and what challenges as well as solutions you met with during COVID?
Sure. Actually, it's the United Arab Emirates. It's not Saudi Arabia.
Oh, I'm sorry. It's in my briefing here, but
sure. So maybe I'll start with actually my journey with ICHOM. So about 10 years ago, I was the managing director of a very large diabetes group of centers in the UAE, where we were managing about 100,000 patients on average, about 40% of the total diabetic population, and in that part of the world, it's 1 in 4 people. So, you know, we used to have a lot of friction with the payer when you have such large populations with such a high prevalent disease burden. You know, the question of are you delivering value comes up all the time. So actually about eight years ago, I sponsored the diabetes set for ICHOM with the national payer in order to prove that what we thought at that time was you know, quality care can be proven once and for all, and then we eventually move towards some kind of value-based reimbursement. Now, you know, what happened is that as we started reporting outcomes, we started realizing that the outcomes itself was not great. Just so you can have a context of, you know, what an outcome looked like there. If we look at, for example, hemoglobin A1C, you know, we were reducing hemoglobin A1C by about 0.9% over 10 years, which doesn't sound very great. You know, especially that the average A1C of that population was about 7.4, which means they're poorly controlled. So this actually led me to, you know, question whether these traditional models of care were actually very effective once you actually have the data. And that was my first journey with ICHOM. My second journey with ICHOM is that a few years ago, myself and my co-founder set up what we believed was the right model to manage a chronic disease burden such as diabetes. So what we've developed is essentially a hybrid model, which consists of both a physical location and a digital health platform in order to shift diabetes care from being episodic to being continuous, and also shift it from being heavily therapeutic to being behavioral-based change approach. And then, you know, a few years ago, we started developing this. We actually opened in the middle of COVID, so Blue Care Health is a diabetes management platform. we started implementing the ICHOM from the get-go, and hence, just a few months ago, we became the first accredited facility globally with this. And for us, it was easy because when you look at the outcomes from traditional care in the context of diabetes or metabolic disease, despite the advances in the therapeutics and the diagnostics and access and patient education and physician education, the actual burden of disease is not getting better. People are becoming more diabetic, they're getting worse off, they're becoming more medicated, and hence, for us, we had to look at new ways of solving this issue, and for us, it was a digital health platform coupled with a physical human-first approach. We don't actually believe completely in the digital-only approach. There are companies that have tried to do there, but that is essentially overlaying a solution onto an existing provider, which doesn't really work. We're kind of privileged and unique in our own way, where we have control of both the physicians and the engineers that develop our tech. And that's unique in the context of healthcare. And it's a different shift towards the thinking. This is how we think we will manage chronic disease moving forward with an implementation of digital health.
And I realized that you have only a few years that you can evaluate, but can you already see an improvement in outcome parameters in the patients that are part of yours?
Yeah, absolutely. So I have the advantage of managing a traditional care for many years, diabetic setting versus this new hybrid model. That setting, on average, reduced hemoglobin A1C by 0.9% over 10 years. This new model of care manages over 2.1% in 90 days. It's completely night and day. And again, it goes back to if a disease is 24/7, the care should be 24/7. And the only way you can actually manage patients 24/7 is through some implementation of a digital health solution.
Mm-hmm. Mm-hmm. Dolores, tell me how Air Liquide and your home treatment program suffered or did not suffer from COVID, and how you tackled your problems there.
Maybe first a word of what we do in Air Liquide Healthcare. So mainly we do two things. We work in two areas. One is home health care. We are treating today 1.8 million patients at home. So it's home and chronic. This is one area. And the other one is we are delivering medical gases and services to more than 15,000 clinics and hospitals in the world. So this is where our playground is. The topic I want to discuss today is home. I mean, during many years, home was the nice place to be. We've been discussing about this in many places. And suddenly the world changed, and home was mandatory for everybody. We were all at home. So everybody started to do things differently. Hospitals started just focusing on COVID. Patients wanted to connect. From the very first day, they wanted to connect remotely. And home care providers like us, we needed to adapt, and we adapted through digital. So we started to do things digital that we never done before. We started at the beginning just to do the less complex interventions that before were done physically. And at some point, we even started to do the complex things in a digital way. So the question is, this will last? We hope COVID opened the world to digital. Not everything will last. We strongly believe in this combination of human and digital, but it really clearly opened the door to do things differently in digital. Maybe as a conclusion, we see home in the future, after COVID, at the heart of future resilient models. So it's not anymore the nice place to be. It's a nice place to be for better outcomes. It's a nice place to be for better outcomes and sustainable models at the end. Maybe we also learned, thanks to COVID, we had the opportunity to speed on outcomes collection. Patients were connecting, so it was easy at a local level or a regional level or in a pilot mode to collect outcomes. The challenge, and this is what I bring to the panel for us, is still the scalability of an outcome collection. So it's easy when we are a country or local or regional level, when you want to collect nationally or when we want to collect from a European perspective or Asia Pacific or Latin perspective, it becomes a real challenge. And for us, it's even more a challenge because we are talking about chronic patients. It's not acute episodes. They will live forever with their disease. So chronicity linked to collecting outcomes is still real a challenge, and I wanted to share. But maybe the challenge, and I give, again, you the floor, is on payments. After the COVID world, we've done many things differently. Payments on our experience, what we didn't see is any big changes on the payer side.
Mm-hmm. So I got stuck on what both of you said, that you believe in the hybrid model. Mm-hmm. And Ihsan, you were very explicit. You do not believe in a digital-only model. Why not? Wouldn't it be possible, for example, for chronic diseases that start mildly, like a diabetes that starts mildly, not with an acute coma or whatever, to make it completely digital?
Maybe for 100% digital to 100% physical, we strongly believe the future is a perfect combination of both. And why we say this, based on the evidence we started to generate, what is the perfect combination that every patient needs, and that we come to the personalization of care. As being a home care provider, we are very close to patients, so proximity is key for us. I like to say we sit in patients' bed. So we are able to understand what are the personal characteristics, what are their behavior, what are the digital preference they have, what is their family looking like, what is the lifestyle of life. So with all this, we're able to personalize the care, launch care plans adapted to each patient needs, and for that, we need digital. So we see the future as a perfect combination of both.
Ihsan.
Yeah, and look, I think digital-only solutions in the context of chronic disease does not work. And I'll tell you why I think that. First of all, in a digital-only solutions, you don't actually have the levers to shift cost or management at the ground level. So these are usually platforms that sit on top of existing healthcare providers. When you look at the value-based context of it, you can achieve some good results on the digital-only solution, but if the physician and the on-the-ground care model is inefficient in its first place, the whole thing, because the majority of cost sits there, the whole thing becomes inefficient anyway. So you don't actually shift the burden of expensive healthcare by adding on another digital-only solution. And the other reason why I don't think it is because a digital-only solution is not for many, it doesn't work for many people. It might work for us. We would adapt more to a digital-only solution. We, are time-starved. It needs a certain level of, education and to be able to access that. But for the majority of patients, for the patient who sits in rural America or rural, United Arab Emirates, they're never going to accept a digital-only solution in a chronic disease setting. They still need to see the physician. They still need to be touched by the physician and interact with that healthcare setting.
Yeah. You wanted to add something, Tom?
Well, yes.
Sure.
Yeah, absolutely agree. And I also believe that the future is hybrid, but simultaneously we are dealing in the future also with more diverse health issues digitally. And we really need to ask ourselves that whether the physical examination adds any value to the diagnostics or decision making. And then we need to ask the patient what does he or she want. And we need to be able to provide both, digital and physical appointments, depending on the patient's needs. And in addition, we need to, develop more holistic and multi-professional digital care pathways instead of, occasional digital medical contacts.
Which actually comes to the point of what Thomas mentioned. So what do we have to actually measure digitally? We don't have an ICHOM standard set for what to actually measure digitally. Currently, everything is on the ground. So, and how much do you do in the cloud? You can be very light touch, you can be very heavy focused on the data collection and interpretation of that. So I think we need more guidance in terms of, if we were to look at a level playing field of providers using a hybrid model, one can constitute a very expensive, inefficient model, but there's a digital aspect to it, and another can perform very, very well. But unless they're measuring the same things in clinic and outside of the clinic, we wouldn't be able to tell.
So we are slowly getting into the second part of this discussion, how would the future look like? And you said we need guidance. What kind of guidance do you need, and where does that guidance need to come from? When you're looking at the future on digitalization, is it going to facilitate value-based practice, or is it going to hinder it? Which guidance are you looking for? You can go, you can continue. You brought up the word.
Okay, look, for us, because our model of care consists of two components, the physical and the digital, currently we get reimbursed for the physical only. Your typical labs, your drugs, your consultations, investigations. Everything that happens outside the clinic, which is where actually the majority of the care happens in our model. Where there's physicians in the cloud, there's devices that we track, there's devices that we give. That's essentially subsidized by the in-clinic aspect of it. So for us, it was very important to implement a value-based approach to show the entire value of the model. So one day, we actually get reimbursed on the outcomes that we perform and we produce versus the services and the minutes we spend managing our patients. Unfortunately, in the UAE, we're still at a fee-for-service model, but one of the reasons why we started looking at the ICHOM standard sets is that these are the sets that will eventually allow us to operate in what we believe is the right way, and the right amount of hardware, software, management in the cloud, to lead to a certain outcome. Bolting on a digital-only solution for the sake of trying to be progressive or more in tune with what everybody else is doing, which does not result in a better outcome at a lower cost, it's not necessary. It's part of the ecosystem. You need to actually drive value, otherwise don't do the digital. If the physical is good enough, then stay there.
Good. Dolores.
What do we need? We need partners. Sometimes we think we can be much faster if we kind of get married with players, digital players that could help us to speed. This is from an early kid side. We need, from the outcome side, we need to be more simple. We are realizing in chronic diseases, sometimes standard sets are still big or complex, so just very more simple. We need some consensus on the standard set or standard sets on diseases that are not covered. We have today 1 million patients suffering sleep apnea, that we don't have a standard set for this kind of outcomes. And then, sorry, but I come back to the next again, we need the payers into the table with us everywhere, which is not today the case, unfortunately.
Thomas?
Yeah, well, I think digital healthcare provides us with better possibilities to adapt and monitor, value-based healthcare practices. And as mentioned earlier, we can create these digital care pathways based on best practices, and we can send information and questionnaires to the patients, and also every decision that the doctor makes in the digital world creates a data point, and we can really monitor whether these best practices are followed. So we have the possibilities and we have the tools, but we also need, yes, I agree, guidance in order to collect similar kinds of outcome measurements, and we get a lot of data, and the difficulty is that what data points are relevant. and what do we use as an outcome measure?
We are talking a lot about patients, but not with patients. Can you envision a future, and maybe you did it during COVID in your turnaround of how you deliver care, how patients were looking at the way you are delivering your care? Did you bring them on to design your system? To maybe Dolores first?
So
did they help you?
Yeah, absolutely. We build it with them.
Okay.
So of course, sitting down with them and then bringing the payers into the discussion all together to even design the care plans and what outcomes are important today, and when doing thousands of surveys to understand them even better. But just maybe the first reaction, when you start to do things differently in COVID, we were kind of afraid what is going to happen. And surprisingly, the patients' feedback was very positive. Because they were really feeling we were adapting for what they really want in terms of channels or way to contact them.
Yeah, and you approached patients individually, or you worked via patient societies, or?
At local level in the companies, in the countries, a lot of medical societies have patient associations, yeah. But then of course a lot of focus groups and even one-to-one motivational interviews or.
And how did you do it in the Middle East, ICHOM? Did you involve patients in designing your digital addition to the physical way of delivering care?
Yes. Look, in the context of metabolic health and diabetes, it's a lot easier because a lot of patients are connected anyway. Some devices. What we did is we overlaid and added further devices in order for us to be able to derive an action from the data that we received. But when a patient came into the clinic, we didn't give them a choice of, would you like traditional care or would you like this hybrid model? We told them everyone is going to go on this hybrid model. It's for your benefit, and here's the data that proves it. There was no resistance in that case because about 75% of the type 2 population is uncontrolled in the country. So, whoever is providing care in the traditional setting is clearly not working. So we tell them, look, this is our approach. After you see a physician, you're going to see an educator, you're going to see a dietitian, and you're going to see a coach who will connect you to a bunch of devices. These devices are something we will provide. We don't expect your insurance to pay for it or yourselves to pay for it. So if you start adding additional payments, no one's going to get connected. So, we give them wearables, we gave them continuous glucose monitors, we gave them, connected scales, and then we started managing their behavior the minute they left the center. And the engagement levels vary. Some are super engaged. They will essentially interact with us on, every 6 hours, and some are not so engaged. In a diabetic population, a type 2 diabetic population, you generally have a very incompliant or non-compliant population, hence the burden of the disease on them. There are ways and approaches to manage a patient like that. You cannot be, you cannot also do a one-size-fits-all. You cannot tell any type 2 diabetic, to stop eating carbs and stop eating rice and stop eating. It never works. It never works for the majority unless they're super, super motivated, which is not the case, at least in the UAE. So instead, we tell them to eat anything they want to. Go and eat as many carbs as you want, and we will observe what it looks like from your personal data. We'll look at your glycemic curves, and then we will start the whole behavioral change approach. We do this in conjunction with medication or with not. So we can also titrate remotely, which patients love that too.
Fantastic. Before we go to the audience, I want to take a sidestep with Thomas. You talked when we were in the prep room an hour ago that you have a shortage of staff, and we know in Finland, and we know that we are dealing with a second pandemic, which is a burnout pandemic in healthcare professionals. Everybody talks about it, everybody writes about it. How does this digitalization, this move to telehealth impact that? Is it a cause of more burnout, or do you believe that it will relieve some of this overstressing the system, at least in Finland?
Yeah, at least in Finland, and I believe in also many other countries, but yes, the system is overstressed. And we have problems in unequal access to care. Depending on, for example, Finland is a large country, the size of Germany, with only 5.5 million people living there. In Germany, there's over 80 million people. And in the northern part of Finland, there are long distances, and also we have long waiting times. We have shortage of personnel and especially nurses. But I believe digital solutions are a part of the solution.
The problem. A part of the solution or
yeah,
of the problem?
Not part of the problem, but part of the solution, I believe. Definitely. And we need to do something otherwise than we have done before, because now the system does not work, and we need to use other solutions and other options, and we need to be as efficient as possible. And yes, it is part of the solution, not part of the problem.
I hope you're right, because if I'm referring back to the Future Health Index that I talked about in the previous session, we have, in this survey, it was shown that all this digitalization that is almost overflowing the healthcare professionals is part of the problem, not of the solution. And I hope we can turn that into the solution part.
Yes, and I want to continue that that's not something that you can add on, you know, the work of a doctor or a nurse. You have to specify time for digital healthcare, you know, part of the day or part of the week. It's not something that you do with your left hand and you treat the patients with your right hand. No, absolutely not.
Okay. Okay.
So that's really important, and you need to involve the doctors in, you know, planning.
Absolutely.
Planning the system. That's important.
Yeah, and just to add to that, I mean, if you were to ask any physician to interpret anything more at their current workload, they will probably refuse it. I mean, if you go today and ask your physician, can you please interpret 3 months of my Apple HealthKit data and check my sleep if it's in sync with what it should be, you know, they would not know how to do it, they wouldn't have the time, they would not know how to get paid for it. So I think in order for digital health solutions to actually have a meaningful role, they have to be somewhat protocolized with the in-clinic access. We need to have physicians look at that data, we need to give them slots, we need to change their model of care. They need to get out of their existing mindset that, you know, it's a scale game of, you know, 5 minutes per patient. That's not going to work with this additional data layer that we're giving them now.
Probably it should be a seamless interaction between digital solutions and human-to-human contact. 7 more minutes for questions from the audience. Oh, there is a lot there in the back.
Yeah, thank you so much for the good discussion. I agree with a lot of your comments. But I wanted to ask you a question, role of digital health in disparity and inequity. And I want to share an example from the US. So I did a lot of digital health, like a lot of the doctors did. And there were patients of mine who couldn't afford a 5G network, who didn't have a device. You could not really do a teleconsult with them. They did not want us to look into their houses because they didn't have a good house. So they would stand on the street or in the park and do that. Then I have patients who have no access to digital media at all. Like, these are people who don't even have electricity in their house. I work with the Amish community. So I almost wonder that sometimes doing this kind of work, so say, and the other discussion that comes up with disparity and inequity is, so if we can do everything digitally, will a doctor ever want to go and work in an underserved area? Because that population will always be asked to do digital health. So aren't we increasing disparity and inequity of care by really pushing this digital health?
Who wants to react on this, how digital is influencing negatively or positively the inequality and the disparity of care? Anybody wants to volunteer? Dolores.
No, maybe to start, I mean, patients say they are happier with that, having the possibility to choose in general. So maybe my first reaction is, and when we started to measure outcomes with different models, when the digital came in for a small percentage, we are just at the beginning, outcomes were better. So my first reaction maybe is that one.
Thank you. Something very strange happened. It jumped from 8 minutes on the clock to 0, fiercely red here. Thank you very much for the panel. I expect you all back if you want to join the third session in this series in 20 minutes from now. Thank you very much.
Thank you.